Okay, moving on to the next question. Even within telemedicine, both of you seem to have picked probably the most difficult subset, that is of tele-ICUs. I say difficult because the cost of implementation of tele-ICUs appear to have been prohibitive even in the US. Uh, Tell us how tele-ICUs are set up, how much they cost, and whether they can be a large-scale adoption in a country like India.
Yeah, that's really interesting that you brought that contrast, because when we actually started this journey into tele ICUs, and when Dilip and I decided to move back to India and start Cloud Physician, it was just absolutely obvious to us that we could not use the same solutions that were being used in the US here in India. They were not applicable. The resource setting was completely different. They were extremely expensive, and for various reasons. Some of them just compliance and regulatory reasons why these systems become more expensive. And so it was clear to us that in India, there was an opportunity for us to actually get take from the learnings that we had in the US, pick the good stuff, leave out the bad stuff, and develop something that is uh, custom made for the Indian resource setting, that would be cost effective, and you would yet address the two other issues of quality and access of care. And so that's really what led us to moving back to India and starting this from the ground up. So one of the things that we did when we started the Cloud Physician was we decided that we would develop the technology ourselves, because the existing technologies that existed out there were ones that were basically hand me downs from the US system. They were technologies that were developed for the United States for their resource settings, and were just sort of brought down to the US and attempted to be implemented here. They didn't really work because the settings were different, and like we mentioned, they were extremely expensive. Even the United States finds it really expensive to implement tele-ICUs because of the cost. And then there are many systems that could use tele-ICU solutions in the United States that simply don't adopt it because the cost is prohibitive. So when we came here and we saw the situation on the ground, uh, more than 90% of hospitals in the country today don't have access to ICU specialist doctors, and there's really no way that our training and deployment system is ever going to address that gap. Not in the next few decades, certainly not in our lifetime. We're simply not going to be able to train enough people and get them to the places that they need to be physically for them to be able to take care of these critically ill patients. And so tele-ICUs were the only solution. Interestingly, what had also happened in the last decade or two is that technology transformation has taken place. So you have connectivity in places that you never had it. You have it cheap. It was never this cheap before. Data is cheap. Bandwidth and data in India is cheaper than anywhere else in the world. Computing power of machines has gone up exponentially, and the cost has come down significantly. So all of these things taking place made it sort of an ideal time to come up with a new solution and implement it in India. And these changes in technology were things that, like Dilip mentioned, that the US, even though it had adopted tele-ICUs initially, was still sort of loaded with legacy systems, and they had problems with different legacy systems. Data is siloed in different places. It's extremely expensive to get data interoperable and get data moving from one place to another. And since we were building a new system, we it was easier to build a system that could address these problems and not be as expensive. So that's with that in mind, that's what sort of made us start Cloud Physician, and that's the journey that we've been on for the last 3 years. Dilip.
Yeah, that I guess that was the second hack we were talking about, right? Is the first one was more, be patient centric if you're having any doubts in the regulation field. And here, when we came back to India, we had a lot of problems, and we had a lot of engineering solutions that were available in the market. And like you said, this was a harder nut to crack, but it so happened to be our domain expertise. So rather than cracking telecardiology or telepulmonology, we just stuck with tele-ICUs. But the second, approach that we did was not to use the pre-existing solutions like Dhruv was pointing out, because clearly they were not working in India. So the hack was to start from the problem at the core and then come backwards. So that's how we kind of happen to be a physician founder led health tech company rather than an engineering led a technology company that also does healthcare. So that was a sort of different take on this. And we didn't focus on the technology actually. We tried to focus on the service, see what problems we can solve at the service end of the hospitals that are in UP or Bihar, and then develop the technology backwards so that we had a more tighter connection. So in fact, we hired our head of engineering only about a year or so after we started the company, which is unusual for a healthcare technology company.
So I think just two follow-up questions there. One is, without giving obviously what may be sensitive data or confidential data as well, if you could share as an indicator, if it costs X to build a tele-ICU or to operate a tele-ICU in the US, what percentage of that have you been able to reduce it to in your current operating environment in India?
Yeah, I would say under 10%.
Okay. Wow. That's that is a very significant cost saving.
But that's really what you need in this in our setting.
Does that open up markets for you outside of India as well? Is it a global solution?
Absolutely, it does. Our goal was to start in India, and there are many other developing countries that have resource settings similar to India that would be ripe for our solution. So certainly it does, and as our solution gets better and better, and I wouldn't say better and better, but I suppose gets more regulator friendly, it would be viable in Western countries as well.
Okay. So yeah, actually, a second follow-up question actually comes a little from my reading of the telemedicine practice guidelines, which Srikanth earlier referred to as well. Worryingly, I think one of the portions of the guidelines actually said that telemedicine services should be avoided for emergency care when alternative in-person care is available, and telemedicine consultation should be limited to first aid, life-saving measure, counseling, and advice on referral. Now, that possibly flies against your whole tele-ICU business model, right? And how do you reconcile this statement in the guidelines with what y'all are doing at this particular point in time?
I think it more than flying in the face of our business model, it flies in the face of the ground reality.
Yeah.
Really,
okay.
That's really what I'd say is that our business model, irrespective whether it's there or not, fact of the matter is that if you had an emergency medicine provider who was qualified at the beck and call of every critically ill patient, and sure, we should never have been here. But that simply does not exist, and is not going to exist anytime in the near future. So that's what I meant to say when I earlier alluded to the telemedicine guidelines being a good first step, but they really need to take into account ground realities and the different use cases in which this can be used to positively impact patient outcomes, very often saving lives. And one of those use cases is in critically ill patients. So I think that needs to be taken into account in hopefully their next iteration. I'll let Dilip complete his thought.
Yeah, sorry, Dilip. Yeah, go ahead.
So what I was trying to say was, I think the intention of the government was that they're trying to sort of give us a common sense approach that when you need a life-saving procedure, the emergency room, which only has telemedicine, is not the place to go. And that's right. You should not have an emergency room without a doctor. That doesn't make any sense. And the point is that anyone who knows telemedicine and tele-ICUs will never make that claim. However, emergencies can happen both in ICUs and in the emergency department. One key thing to realize is that ICU care is not emergency care. Emergency care is when someone comes to the healthcare facility for a rapid onset medical problem that happened in their house, for example. ICU is when you have patients who have been transferred from the emergency department or from their house for continued care in the ICU because one or more of their organs are failing.
Mm.
So it's for continued care. So it doesn't fly in the face of traditional ICU medicine because ICU medicine is sort of an emergency in slow motion that happens continuously. To put it in perspective from a layman's angle, an ICU care is where all your organs or one of your organs are failing. You have been transferred from the emergency room because you're so sick at a steady level that it's not a one-off fix. You need continued high level of care. Now, that is where a tele-ICU has a unique advantage to allow rationing of the already scarce resources. So when you are trying to understand and unpack that statement, it's important to realize that critical care is different from emergency care. They may be related, but they're definitely not the same. And one thing that we would encourage is to look at something which is an easy example of that, which is CPR. CPR is cardiopulmonary resuscitation, which you see in movies like or shows like Grey's Anatomy, where your heart is stopped, someone jumps on your chest and you're pressing on the chest, you're giving a shock to restart the heart. It's a very simple set of guidelines that make sure that CPR is done properly. It happens in the emergency department and it can happen in the ICU. It can happen in any office as well. The point is that if you have someone who's telling you that this is the right timeline to follow and this is the right set of medications to give and this is the correct speed at which you're compressing the chest, the outcomes, the chances for that patient to survive that CPR is higher. What I'm trying to get at is that this can be done through remote care. So you can have somebody who's doing the CPR at bedside, and you can have a remote system through a tele-ICU system, for example, that can make sure that these guidelines are met. And one of the initial reports from India is actually a report from our team where we have a 25 patient case series of tele-CPR that makes the bedside team's CPR ability more structured, more in line with published evidence, so that patient who's receiving CPR in the remote center actually gets CPR that's in line with international standards. So again, not replacing, but complementing and making sure what's happening at the bedside is actually quality stuff.
Very insightful, I would say.